diagnosis. It's a clinical syndrome and a clinical diagnosis. It's sudden facial pain, usually of memorable onset. Most tic patients can tell me, I was walking across this little bridge while we were on vacation, and suddenly it was like somebody stuck an electric wire to my face, or I was brushing my teeth and it just hit me like a bolt of lightning. So I mean, they remember when it first hit them. It lasts less than a minute. Now, when it first starts, it lasts less than a minute. It can mature, and especially on some of the medications, it can change its character. So because you don't have these brief lancinating bouts of pain later in the course of the disease doesn't mean you don't have trigeminal neuralgia, but when it starts out, this is the way it is, or it's not trigeminal neuralgia. It's not tic Douloureux. Paroxysms, as you all know, you can have them for a while and then they go away and then they come back, and you can have them for a while, they go away and comes back. You say, oh Lord, please spare me, I don't want this to ever come back again. And you have this hope, and if the psychologists say they can make the pigeon bloody his beak by giving him a corn only 1 out of 7 times when he strikes it. So if you go 1 week out of 7, you go 6 weeks out of 7 without pain, you think, oh, I'm going to be free. It's not going to come back again, but then it does. So finally you get tired of it and look for something to do. It's always confined to the trigeminal nerve, or else it's not trigeminal neuralgia. The trigeminal nerve, I did some studies with Dade Lunsford years ago when I was a resident in Pittsburgh, and we did a lot of glycerol rhizotomies. That was a new thing at the time. And so we numbed the nerve up, and we would check people's heads to see how far back the trigeminal nerve actually went. And we found that in many cases the trigeminal nerve actually went all the way back to the back of the head. So that people with lancinating hemicranial pain actually had trigeminal neuralgia, even though the classic is face in the 3 divisions. The first division could go all the way back on the side of the head. So that in some patients, of course the usual triggers, it always somewhat responds to the neuroleptics. If it doesn't respond to the neuroleptics, then you may not tolerate the neuroleptics, but if it doesn't get better, not maybe go away, but doesn't get better to the usual Tegretol, Dilantin, the Neurontin, and so forth, then it's certainly not typical trigeminal neuralgia. They almost always gets better with that. And the neurology books say normal neurologic exam, but that's not entirely true. Some people, on detailed examination of the face, I can usually find either a slight change in the corneal reflex on the affected side, or I can find some areas of numbness, and that corresponds to abnormalities in the trigeminal nerve itself. And then it almost never awakens patients from a sound sleep. And I'm not sure why that is. I think it's because as we sleep, our blood pressure goes down, the artery isn't banging into the nerve, and we just kind of, everything gets quiescent there. And then I didn't put it up here, but it's frequently, though not always, positional. So that patients say, I can't go to sleep if I lie on my right side, because I lie on my right side, I get my triggers, or maybe the artery, the brain settles somewhat, our brains kind of move around in our heads. And the most important part, since this is a clinical syndrome, you've got a workup that's negative for all other etiologies, all those other things, the vascular, AVMs, tumors. In the days before MRI, that was a very important distinction, because there was about 5% of people had tumors, AVMs, or something else going on inside their head, but now MRIs are good enough that that sort of stuff gets picked up. So if you've had a high quality MRI with and without contrast, high quality, 1.5 Tesla or greater, and you have the syndrome, that pretty much excludes anything inside your head that's making you have the face pain. The other course, the rest of the course of the nerve